Hello, everyone, and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. Thanks for joining us. We will begin soon. Please know that we are recording today's presentation and you will receive a follow-up email from us with a link to today's recording and additional resources in about 1 week. Thanks for being here. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language series, EP Salud en Casa. Be sure to visit our website by scanning the QR code with your smart device and to see what's coming up and explore archive videos on YouTube. This weekend, we launch our 9th annual Care Partner Summit on Saturday, November 8th. This year's theme is Caring with Confidence, and we will include expert insights from neuropsychologist Dr. Taylor Rush from the Cleveland Clinic, as well as having a full panel of care partners who are living the experience of supporting someone with Parkinson's from a diverse background. So please join us this Saturday, November 8th for our Care Partner Summit. Caring with Confidence. You can learn more and register at parkinson.org/care summit. Today's PD Health at Home Wellness Wednesday webinar offers an introduction and basic overview of Parkinson's disease. PD varies from person to person and changes over time. We'll explore the causes of Parkinson's, common symptoms, the available treatment options, and effective strategies for managing symptoms. We will also learn practical daily living tips to empower you to take charge of your health and to navigate the challenges of living with Parkinson's. Leading the presentation today is Dr. Kristen Matulis. Dr. Kristen Matulis is an adult and gerontological, that's a big word, gerontological nurse practitioner specializing in movement disorders at the University of Texas Health Science Center in San Antonio, a Parkinson's Foundation Center of Excellence. Dr. Matulis earned her BS in nursing from the University of Texas at Austin and her Doctor of Nursing Practice from the University of Minnesota. She also completed the Parkinson's Foundation's inaugural Movement Disorders Nurse Practitioner Fellowship at New York Presbyterian Columbia University in 2023. Her clinical practice focuses on neuromodulation and Parkinson's disease with a special emphasis on deep brain stimulation. Beyond her patient care, Dr. Matulis is passionate about advancing education and training for nurse practitioners in movement disorders, helping to expand access to expert neurological care across communities. Dr. Matulis, thank you for joining us today.
Thank you so much, Krista, for that very kind introduction. You're the best. I want to thank you all so much for coming and being with us today. There's a lot of things that you can be doing at whatever date and time it is, whatever part of the world you're joining us in. So I want to thank you all so much for taking the time, because I think it just shows the commitment to learning more about Parkinson's and being an advocate either for yourself as a person with Parkinson's or a care partner or loved one. I'm going to go ahead and share my screen and we're going to get started here. Perfect. All right. So as Krista mentioned, what we're going to be covering today is Parkinson's basics, basically scratching the surface on all of these portions of Parkinson's disease, from the symptoms to the treatment to the progression and all of these items. So what I want to start with is some objectives and what we're going to cover today. What I want to start by saying is that this presentation, as I mentioned just a few seconds ago, is going to be scratching the surface, if you will. I know some of you might have really in-depth questions that have to do with your specific disease course, but what I'll say is not only is Parkinson's different for everybody in how it presents, but it's also different in how it progresses, how you respond to treatment. And so I'll do my best at the end of the talk today to answer any questions that you all have, but Please know that it's always best to follow up with your neurologist, your nurse practitioner, your physical therapy team, whoever is helping you manage your symptoms and care. And in addition to this, although I would love to cover every facet of PD in this 45 minutes to an hour with you all, it's just not possible. So what I will also say is please follow with the Parkinson's Foundation and their amazing library of resources that are available after this talk. There are also routine webinars that are constantly coming up, as Krista alluded to at the start of this presentation as well. So while we will get into each of these testaments of Parkinson's disease, I just wanted to start with those initial thoughts. So let's begin with what is Parkinson's disease. Parkinson's is a neurological or a nervous system disorder. It's chronic, it's progressive, and unfortunately, there is no cure. However, with that being said, the symptoms can be treated effectively and really improve the quality of life with our people living with Parkinson's disease and their care partners. Parkinson's doesn't only affect movement, but it can also affect other parts of your presentation, including mood and thinking. Healthy lifestyle choices can be paramount in the management of PD, and we're going to go through those today in addition to some medication options and things of that nature that can help with the management of Parkinson's disease. What I want to reiterate again is that there's so many resources out there and there's so much that can be done. There's a whole care team that's involved in the management of PD, and we're going to go over all of that. So who's affected by Parkinson's disease? What I'll say is that Parkinson's does not discriminate. There are an estimated 1 million people throughout the United States with this illness and 10 million people globally. It's estimated per data from the Parkinson's Foundation that there's roughly 60,000 new cases of Parkinson's that are diagnosed each year. Parkinson's is fast growing, and it's actually the second most common neurodegenerative illness outside of Alzheimer's disease. PD can affect men, women. It does not discriminate to certain races, ethnicities, and it can even affect people of younger age as well. Older age can be a prominent risk factor in the development of Parkinson's, but there are a small number of people that can develop PD much earlier in life. Sometimes as early as late 20s, early 30s, although that's quite rare. As some of you may be aware, I know Michael J. Fox had a documentary that was released on Apple TV, and I believe his tremor started at age 29. What I'll say is that that's certainly not the norm, and it's not common to have symptom onset that early, but it can happen. We do have a cohort of our young onset PD population that is usually indicated by a diagnosis under the age of 50. Now, what causes Parkinson's? This is a big question in part because we don't fully know. Scientists are still studying this and believe that it could be a combination of factors, including genetic, environmental, things of this nature. So what I'll say is that Parkinson's is rarely inherited or it's rarely hereditary, passing through the generations of families. I start with genetic in part because the Parkinson's Foundation is running a fantastic study called PD Generation, where they're trying to collect up to 500,000 samples from our people with Parkinson's to better understand genetic links in PD. Usually 10 to 15% of people have a gene that's implicated in the development of Parkinson's. However, what I'll say is you could have a genetic link and never develop the disease. So it's a very interesting phenomenon and something we're still studying. Further, some studies have demonstrated that certain chemicals and prolonged exposure to occupational hazards or chemicals out in just our day-to-day lives, whether it's dry cleaning chemicals, pesticides, if you live in a community where those are being utilized, these exposures can also cause this neurodegenerative illness as well. Dr. Michael Oken and Dr. Ray Dorsey just came out with a book, The Parkinson's Plan. It's a New York Times bestseller. It was just released in recent months. Really goes through which toxins are implicated in the development of Parkinson's and really goes through those risks as they exist. In terms of other risk factors, there are other things that are thought to contribute to Parkinson's onset. As I mentioned, older age could certainly be a risk factor for development of this illness. Further, traumatic brain injury can also be implicated. I'm sure many of you know the famous boxer, Muhammad Ali. He was diagnosed with Parkinson's disease. And again, although we can never be sure what causes onset, it's thought that the potential participation in boxing did contribute to onset of his illness, given the repeated brain injuries. So further, what's happening in the brain when we have the development of PD? Ultimately, Parkinson's is made up of a degeneration of the nerve cells in the brain that produce dopamine. So usually there's a slow degeneration of these dopaminergic producing cells in the brain, and this is located within the substantia nigra of the brain specifically. But usually patients will start to exhibit symptoms when 60% or so of those dopaminergic neurons have degenerated and died. So as a result, there can be some prodromal signs of Parkinson's that can occur prior to onset, as we'll go into in this talk, the early signs of Parkinson's symptoms that I have many patients come to clinic and say, wow, I didn't put it together until I got my diagnosis and learned more about these early symptoms and what could be occurring. And I put together that it may have been related to the onset of my PD. So ultimately, the main neurotransmitter that's implicated in Parkinson's disease development is dopamine. However, there's other neurotransmitters that can also be impacted by the onset of this illness. Ultimately, acetylcholine, which can help with memory, serotonin, norepinephrine that can help with mood. All of these neurotransmitters can be disrupted. As a result of these deficiencies in the brain, we can have discoordination of movement, issues with speech, issues with sleep, trouble thinking, and issues with anxiety and depression as well. So again, reiterating that there are more things that are implicated in PD than just those movement symptoms. So what should you know about symptom onset? As I just kind of went through, there's many systems in PD that are affected throughout the body. There are non-motor manifestations that are not related to movement, and the motor manifestations. Those can include tremor, stiffness, slowness, and postural instability. So those are the kind of the four cardinal features associated with the motor signs of this neurodegenerative disorder. I love this iceberg photo that's on this slide because this is a true schematic of what we see in Parkinson's. You see the top of the iceberg coming out of the water and it's visible to the human eye, but there's all these things happening underneath, which really embodies the non-motor symptoms that a lot of people can't see. You know, we can't see internal tremor that a person with Parkinson's will feel. We can't see or embody the sleep issues that are occurring or the sense of smell that's been decreased. And we'll go through all of these symptoms during those early signs that we'll discuss. Again, as I mentioned earlier in this presentation, Parkinson's disease truly varies so much from one person to another. I can line up 10 of my patients in a room and have them all next to each other, and I guarantee you everybody's motor function will be different and their non-motor manifestations will be different as well. I caveat this as well because this also affects treatment. You know, when there's so many different ways that PD can present in the population, we can see these changes from person to person, and they might not all respond to medication or other therapies the same way that somebody else will. So let's talk a little bit more about the motor symptoms of PD. As I mentioned just a moment ago, those four cardinal signs are very well known as motor manifestations in PD. Resting tremor, or tremor that is noted in the hands, the legs, the head, the neck, the jaw, can be noted. Further, what we refer to as bradykinesia, which is a slowness or a trouble with movement. Somebody might not be moving as quickly as they did prior to onset. Additionally, stiffness, which we as clinicians refer to as rigidity when we're examining a patient, can occur in the extremities, the head, the neck, the joints, can be very bothersome to patients and sometimes painful as well. Further, problems with walking can be noted quite often. Issues with balance. People might fall. They might have difficulty getting up from a chair without falling back into that chair upon standing. So these are the true hallmarks of those motor symptoms in Parkinson's disease. And again, they look very different from person to person. In terms of the non-motor symptoms, I do want to go into each of these a little bit more in depth. I know I've been alluding to them up to this point in the presentation, but I want to start first with mood. So there can be a constellation of mood symptoms that occur in the development of Parkinson's disease. A patient can experience depression or what we call loss of interest and loss of motivation in doing things they once loved, which is known as apathy. These symptoms can be a little difficult to treat, although there are medications that we can give to try to boost the motivation and the mood to get people back to what they enjoy doing. Further, anxiety can be quite prominent in Parkinson's. I have many patients that come to me and they say, I've never been an anxious person, and now I can't sleep well. I have racing thoughts at night. And ultimately what I tell them is that it's not you, it's the neurotransmitters that are not functioning the way they should in the brain. So a lot of times it's this manifestation of these mood symptoms that are occurring because, again, those changes in norepinephrine, serotonin, acetylcholine, and the dopamine, which can be quite prominent. In terms of thinking and memory, this can also be implicated. Usually acetylcholine is the neurotransmitter that's implicated in memory in Parkinson's. People with Parkinson's can have difficulty paying attention, learning new things. They might have slowed thinking, which we refer to as bradykhrenia. So it might take them a few moments to get the words out that they're wanting to say just because of that slowed processing. Further, there can be difficulties with remembering words or people's names and some forgetfulness. I see a lot of times people come in indicating that they're having short-term memory issues. I can't remember that we had something scheduled for next week that's been on the calendar, things of that nature. Further, some people have trouble with soft speech, which we refer to as hypophonia. I have spouses and care partners that come in and they say, I just cannot understand what my loved one is saying. And that is a result of the PD as well. Usually there is a manifestation of staying asleep or falling asleep too much during the day. This can be a component of fatigue related to Parkinson's itself, or it can be due to the medication. So any of the medications that we use to replace dopamine can cause low blood pressure, some tiredness, so they can affect fatigue during the day. Further, there could be risk of hallucination and delusion development. What I reassure people of is that this usually happens much later in the illness. If we're seeing a sooner onset of hallucinations or delusional thinking, then sometimes we're going back to the drawing board in terms of our differential diagnosis. And we say, are we sure we're talking about idiopathic Parkinson's, or is there something else that could be going on as well? Hallucinations could also be the result of medication. So it can get complicated because there's this combination of symptoms that can occur as a result of the Parkinson's disease and as a result of medication that we prescribe for management. In terms of constipation and bladder, what I would like to add here as well, some people have trouble moving their bowels regularly. They strain when they're trying to go to the bathroom. And there can be urinary difficulties as well, maybe going to the bathroom too frequently, not emptying fully, things of this nature. So as I mentioned earlier, and we've covered some things on kind of a surface level, but I want to go deeper with all of you and talk about the 10 early signs of Parkinson's disease. What I want to caveat, and I'll mention this throughout the next portion of this talk, these symptoms independently do not necessarily indicate a diagnosis of Parkinson's disease. What we see is that when we're putting the pieces together, when somebody comes to clinic, they see us either from referral from their primary care doctor, they've sought out a movement specialist or a neurologist, and our team is seeing them to establish care. We're asking a combination of questions related to this. What do these look like as a whole, not individually? So If you are listening to this and you're resonating with one symptom that you have, I want to reassure everybody it does not necessarily mean that there's a diagnosis of Parkinson's. So what we'll start with is tremor. As I mentioned earlier, this can start very subtly. It can be in a thumb, a pinky finger, a little bit in the lip or the jaw. Everybody's different, but shaking can be caused by other things as well. It could be medication-induced tremor. It could be related to other issues in terms of an injury or stress, high emotion, things of that nature. So it's good to keep an eye on this, but there could be other things that cause it as well. In terms of small handwriting, we call it micrographia here in the clinic. People will come in and they'll say, oh my gosh, my handwriting is messier than it used to be. My partner or my children can't read what I'm writing. I feel like my handwriting is very small. These are manifestations that could be related to Parkinson's. Again, could be related to other things too. If there's an arthritis of the hand or the wrist, if there's a recent injury or a surgery, that could certainly cause issues with writing. So really looking at this again as a constellation of many symptoms that could be related to PD. Loss of sense of smell. Now, this is an interesting one, and I brought it up very briefly earlier, but we call this hyposmia, and ultimately what it is a result of is dopamine deficiency. And we see this as sometimes an early or prodromal sign of Parkinson's. It's very interesting though, because the COVID pandemic, as everybody remembers in 2020, also impacted people's sense of smell and taste. So I have had some patients, when I started my fellowship at Columbia in 2022 in June, July, I had many patients coming in as we're coming out of the COVID pandemic saying, I thought it was related to me having COVID. And then they developed other symptoms like the rest tremor, the small handwriting. And as we're putting the pieces together, we actually find that that reduced sense of smell is related to that dopamine deficiency in the brain. So it's very interesting. Of course, similarly to these other symptoms I've described, loss of sense of smell alone does not indicate a diagnosis of PD. Sense of smell can be changed by having a cold, having the flu, things of this nature. Now, trouble sleeping. This is another one. Interestingly, there's a couple facets of this. So first, what I'll say is that a person with Parkinson's can have involuntary movements during sleep that can be quite prominent. So oftentimes it's a bed partner that comes to clinic endorsing these symptoms. But what we have is the patient or the person with Parkinson's kicking, hitting, punching during sleep. Sometimes there's a manifestation of falling out of bed in the middle of sleep overnight, and the partner is waking up and the patient does not know how they came to be on the floor. And that could be because of the result of these involuntary movements that occur during REM sleep. What we call this is REM sleep behavior disorder. Interestingly, and we don't fully understand the mechanism, but for some reason during sleep in Parkinson's, when you hit that deep form of sleep, that REM sleep, normally what happens without a dopamine deficiency in the brain is somebody is paralyzed during sleep. They dream, they don't move. For some reason, this is inactivated in Parkinson's and people have these involuntary movements. I apologize, everyone. This is moving forward without my permission. They have these involuntary movements that cause them to have true dream reenactment. I have patients that will come in, they're having vivid dreams of fighting people and they're physically fighting people in the bed during sleep. This could, of course, cause risk for injury to our patients, their bed partner, whoever they're sleeping with. So it's something we screen for every time when people come to clinic. Further, there can just be sleep difficulty in Parkinson's. As I mentioned, it could be the result of a mood issue where there's a lot of anxiety happening. Person's thoughts are racing, they can't fall asleep, they can't stay asleep, or it could just be a manifestation of being underdosed and having reduced dopamine. So it's complicated. Now, trouble walking. Again, as I've mentioned before, trouble walking alone, not necessarily a sign of PD, but what we see is that somebody with postural instability where they have a tendency to fall, somebody that maybe has a lot of stiffness that causes them to have a stooped posture and a shuffling walk could certainly be implicated in the diagnosis of Parkinson's. Of course, arthritis can be implicated, other signs as well of walking difficulty, but we do look at your gait when you come to clinic if this is something that is happening in the setting of these other symptoms as well. Going back to constipation, I know I mentioned this earlier as well. People with PD can sometimes strain when they're trying to have a bowel movement. It can be painful to pass stool. It can be difficult to pass stool. I have some patients that come in saying they only go to the bathroom once or twice a week. So when this is the case, what we try to do is treat this with medication therapy. Again, constipation in itself is not a diagnosis of Parkinson's, but it can be an early sign. Now, in terms of soft or low voice, I mentioned this earlier as well, hypophonia. Um, that softness that can happen. But again, other things can cause this as well. Vocal cord dysfunction, a cold, a respiratory illness can change the composition of the voice. So it's something we certainly ask about when people come in, but again, independently is not going to be a sign of Parkinson's in itself. Now, in terms of a masked face, this is what we also call a poker face. People will notice that they're not as expressive as they used to be in Parkinson's. I have loved ones or care partners that come in and they'll say, he or she is just not as expressive as they used to be. The mouth can hang open, the eyes have a reduced blink rate. So there's many things here that can occur that can be indicative of this facial expression in Parkinson's. Again, other medications, such as meds that block dopamine, some antipsychotics, things of that nature, can also cause that expression. So again, looking at it as a constellation of symptoms, it's certainly what we screen for when you come to clinic. In terms of lightheadedness and dizziness, this is another one of those complicated symptoms that can be the result of Parkinson's disease, sometimes as an early sign, or it can be due to medication later on in the illness after you start medication therapy for PD. But this can also be the result of dehydration. I know living down here in San Antonio, Texas, our climate is quite hot. So I have to remind people a lot, please be drinking just to maintain that hydration because the dizziness alone may not be related to Parkinson's in itself. I mentioned this earlier, so I won't go into depth with this, but again, that stooped posture or hunched over look when somebody is ambulating can be a sign of PD. I have some patients that come in and say, I'm leaning to the left or I'm leaning to the right. I have care partners and caregivers that will come in saying, I have to straighten them up in the wheelchair or in the chair and make sure they're sitting nice and straight. So again, as injury, arthritis can certainly affect this, excuse me. It is a sign in itself when it's paired with all of these other early signs that it could be indicative of a diagnosis of PD. So now that we know all of that information, it's a lot, right? Let's talk about diagnosis. What I want to say here is that receiving proper treatment and expert care in terms of Parkinson's care can be really paramount in altering disease course, just because it can really impact people's quality of life and improve it throughout the disease course over decades that a person will have Parkinson's. This is why we always recommend that it's important people get care as soon as possible. Now, talking about diagnosis, as I mentioned, there's a lot of questions that we ask people when they come to the clinic. And ultimately what we find is that people, the biggest way that we diagnose Parkinson's disease is through clinical assessment with a neurologist. So that's what I'm getting at when I say you're going to come in, you're going to have a lot of questions that are directed at you, your care partner or your caregiver, whoever's with you, because we want to really get a great history and do a good exam just to ensure that people are, getting that comprehensive history and getting that full look from the movement disorder specialist or neurologist. Because what we want to do is make sure that we're comprehensively looking at everything, because ultimately there's no surefire test that will confirm PD. Parkinson's disease is not something that can be diagnosed with an X-ray. It's not something that can be diagnosed with a brain MRI, and it's not something that can be diagnosed with a blood test. So historically, what we've relied on is clinical assessment and examination. Something else that's a part of this that we sometimes use if there's a question about clinical diagnosis and are we sure that this is what we're looking at? we can use the DAT scan. This is a scan that will look at dopamine deficiency in the brain, and can be helpful in confirming the diagnosis or supporting it if a clinician is thinking that this is the possible diagnosis. Further, skin biopsy testing has become more common as well. This is a little bit newer, but it is something that we use here in the clinic to help really, again, support that diagnosis if there is uncertainty. What happens in Parkinson's is there's also a misfolding of protein called alpha-synuclein. And what the skin biopsy looks at specifically is that misfolded protein, but in the skin. So what they do is they take a little punch biopsy from 3 sites. It's going to be at the back of the neck in the cervical spinal area. It's going to be on the lateral outer portion of the thigh of one of the legs. And then it's going to be on the more distal portion or lower down on the leg, right above the ankle bone that we'll take those biopsies from. And then ultimately it helps us determine, is there that aggregation of alpha-synuclein that's supportive of a diagnosis of Parkinson's? Now, when to start treatment? This is a very individual decision. Everybody's going to be different in terms of when they elect to start treatment and how they do that. And usually that decision is made collaboratively with your clinician. So ultimately, the goal of treatment is to manage symptoms. What I'll say, as I mentioned earlier in this talk, is that unfortunately, there's no cure for Parkinson's disease. At this time, we don't have a disease-modifying medication or therapy that is going to stop the progression of the illness or reverse the damage that has been done with that dopamine deficiency in the brain. Again, treatment options are vast in the Parkinson's community. And those, again, will be very tailored to each individual person when they come to clinic, see their clinician, or another member of their team. But it really is dependent on a person's needs based on what their symptoms are. So there's a variety of things we can offer people, but it will vary from person to person. Now let's talk about building a team, because I've been kind of referencing intermittently as we've been chatting that there's a whole lot of people that are involved in the care of Parkinson's and are there to help our people with Parkinson's and their caregivers. So first and foremost, this is bolded because if there is an opportunity for you to have a movement disorder specialist, I always recommend this. These are neurologists that have had extra fellowship training in the field of movement disorders. So these are physicians that are very well trained in the management and treatment of Parkinson's, the diagnosis of Parkinson's disease, and are aware of its progression and how it will manifest over the decades. Further, depending on availability, we also have amazing general neurologists that our patients will see out in the community because they might not be able to get to a movement specialist all the time for each appointment. So it might be that we have people that see a movement doctor once a year and they see their general neurologist more regularly in the community, wherever they live. Also, nursing. I'm biased as a nurse practitioner, but I have to say that I really am so happy that we have so many fantastic nurses that are out in the community that are helping advocate for and work with our people with Parkinson's and their caregivers. Further, physical therapy, occupational, and speech therapists are paramount, and we work with them very closely. I know here at UT San Antonio, we're about to move to a Center for Brain Health building right next door that's going to be comprehensive care, all neurology. And our neuro, physical, occupational, and speech therapists are all coming with us. So we're very excited about that. In addition to this, our social workers are so important in the care of our people with PD. They really help us with home care setup, establishment of resources out in the community, and outreach activities. When we get to go to conferences or symposiums and get out in the community and we get to talk to people, our social workers facilitate a lot of that, which is amazing. Further, psychiatry and psychology can be so helpful because, again, there's these mood manifestations in Parkinson's. Additionally, if somebody is being worked up for a surgical intervention like deep brain stimulation, psychology can be really helpful because they help us kind of determine if there's any underlying cognitive issues before somebody goes into surgery. They can also help us at other stages of the illness. When somebody's reporting cognitive decline, oftentimes I'm working very closely with my neuropsychology team to get people screened, which is really helpful. Further, Our pharmacists are amazing at helping us look for drug interactions, potential issues that could be occurring with script writing, things of that nature. So we love our pharmacists as well. I also want to mention, because there's a whole slew of other professionals that are not listed on this slide, but what I'll say is we have our dietitians who are fantastic, our health coaches, there are support group leaders out in the community and community health workers that are paramount in helping our people with Parkinson's. So the list really goes on. I'm sure each of you maybe have your own experience with a person that's on your team that might not be listed here. Now, in terms of finding the right specialist, I really wanted to take a moment here and plug that the Parkinson's Foundation has a fantastic helpline that can help get you connected with an expert in your area, whether it's a physical therapist, whether it's a movement doctor, whether it's a nurse practitioner who manages things out in the community. So if everybody has a moment and you have something to write something down, or if you want to take a picture of this slide, this phone number is so helpful. I've met the healthcare team that is involved with the helpline, and they are absolutely fantastic and so knowledgeable. So I really wanted to share that resource. Now let's talk about treatments. Again, this is going to be scratching the surface. There are so many things that we can do in Parkinson's disease now. Many years ago, there was one company that did deep brain stimulation, and there was levodopa. And that was about the extent of what we had available to manage people's symptoms and improve quality of life. Of course, in addition to regular exercise, good diet, utilization of our therapists, all of these things. But now there's many medications that are available, so I will not be able to go through each of them today or in depth, but I highly encourage you speak with your doctor if there's things that are bothering you, just to see what can be done to manage your symptoms more effectively. I know I brought deep brain stimulation up a couple of times in this talk. That is my specialty area to a degree from my training at Columbia. So again, I won't be able to go super in depth in terms of DBS and other surgical options, but we will cover it briefly today through the latter portion of this talk. So in terms of exercise, there's a reason that we're covering this first, and I'll say that it's because exercise is the only known intervention that will slow the progression of Parkinson's. I know earlier I said there's no disease-modifying therapy that we can give you in a prescription. What we can prescribe, though, is physical exercise. Not only does it help with mobility, but it can help reduce fall risk, it can help with balance, it can help with strength, flexibility, all of these things. It also helps with a lot of secondary benefits. Exercise can help with mood, alleviating anxiety, depression, apathy. It can also help alleviate constipation. Good movement is going to get those bowels moving as well, which is hugely important. Further, sleep. Sleep can hugely be affected, as I talked about earlier, in PD. So exercise is a fantastic way to kind of help regulate sleep a little bit. So there's so many benefits to this. There's rare contraindication. Of course, everybody needs to work with their own doctor to figure out what's going to be right for them in terms of the amount of physical activity, what type of physical activity, how robust should that activity be when you're doing it. But there's a number of options, whether you like chair yoga, biking, running, swimming, walking. All of these things can help the brain in terms of establishing a good just neuroplasticity, but also kind of boosting dopamine levels in the brain naturally. So this is a fantastic intervention, and I encourage everybody to do it. In terms of nutrition, we love to recommend the Mediterranean diet usually. This can include oily fishes such as tuna or salmon, dark leafy green vegetables like spinach, and we always recommend colorful plates. If your plate looks beige, there's probably not enough nutrition on that plate. So we always recommend also lack of fried foods. We don't love fried foods, just not great for the brain. So these are the things we usually say to supplement medication therapy, exercise, all of those things. In addition, I really encourage hydration in my patients, 6 to 8 glasses of water a day, unless you've been told by a cardiologist or another specialist that they have to limit your fluid. If you've never been told that, then we always recommend up to 64 ounces a day of water. Another big question I get usually is, does coffee and soda count? And the answer is no. Anything with caffeine can dehydrate you. So it's important to avoid those specific drinks when you're intaking and counting your total glasses per day. So something to keep in mind in terms of those nutritional recommendations. Now let's talk about mood and relationships as well. Support groups can be fantastic, and the Parkinson's Foundation helpline can also assist, I believe, with connecting people with local support groups. If you see somebody that is involved with the Parkinson's Foundation Center of Excellence, there should be support group options in person as well, which is incredible. Some of them are online. I know in New York City, when I was at Columbia, it could be very difficult for people to get into Manhattan. So we always had virtual options so people could join from anywhere through the tri-state area and beyond. Further, individual counseling and psychotherapy can be a great adjunct therapy for treatment of anxiety, apathy, depression, and also adjustment to a new diagnosis. I want to take a moment and acknowledge that hearing from your clinician that they suspect that you have a diagnosis of Parkinson's disease can be quite jarring. So it's important to have these other supports on board and ready to go, just to be able to seek those assistances where they're needed. I also want to say that there are support group and counseling options for our care partners and our caregivers. I'm sure there are care partners and caregivers on this call that have joined either with their person with Parkinson's or their loved one. So I just want to acknowledge that the work that all of you do is so important and I think can sometimes be under acknowledged. We really try in the clinic to take a moment when people come in for their follow-ups and say, hey, I have to check in with you too. Are you taking care of yourself? Are you sleeping? Are you eating regular meals? Are you spending time with family? Are you getting out with friends? These are all things that are important. So I want to acknowledge for our caregivers that there are these options out there for you as well, which is important. And family therapy can be helpful for that as well, kind of bringing together the person affected by Parkinson's disease, the family member or caregiver, and a family therapist as well to kind of work through things as they come up. Now let's get into medication. Again, a super basic overview. I will say quickly that in 2024, 2025, we had a whole slew of things that were approved by the FDA. So there are new things coming out to market, which is very exciting. Most recently, the phospholevodopa pump, which I'll go into in a moment, was approved and people are experiencing some benefit with it, the ones that are wanting to try it and we think would be appropriate for use. Now, what I want to caveat too is Parkinson's disease changes over time. There is dopamine loss in the brain over time because there's no way for us to stop that with a medication. The way that these medications work is to supplement dopamine in the brain. As I mentioned earlier, levodopa is the gold standard of treatment. It is quite an old medication, I believe developed in the late 50s, early 60s, and it has still to this day been the thing that we start people on first after a diagnosis in most cases. I would say when somebody starts medication, it's usually a regular levodopa that we kind of trial people on. This medication converts dopamine in the brain, whereas dopamine agonists, a different class of meds, they act like dopamine, but that also can cause side effects in the sense that dopamine agonists can be a little bit more pronounced with causing compulsivity and impulsivity in our people with Parkinson's. So I would say in my practice and of my colleagues at the centers that I've worked at where we're not reaching for these as readily anymore just because of the risk for side effects, but they can be very effective if tolerated. MAO-B inhibitors. So these medications actually block the enzyme that breaks down dopamine in the brain. So it's not giving you dopamine via this enteral method. Rather, it's just preventing the breakdown of the dopamine that's in the brain. These are your rasagiline, selegiline. The COMT inhibitors can be very effective as well. These include entacapone, opicapone, things of that nature that can be very effective at kind of helping prolong the life of levodopa in the brain and the body. Surgical options. So as I mentioned, deep brain stimulation can be utilized. This is a minimally invasive procedure, but still is brain surgery. So I always caveat that to my patients. There's two leads that go in the brain. Sometimes people start with one lead being placed rather than two. And I know in New York, I had some people that had up to 4 leads in the brain. So again, everybody's very different in terms of how symptoms are managed. Deep brain stimulation can be very effective because it can, in some cases, allow for medication reduction up to 50%, which is quite a bit if that pill burden is reduced by that much. So it can be quite effective, again, at improving quality of life. DBS does not reverse or prevent the progression of Parkinson's. Rather, it's another tool in the toolbox to manage symptoms. Further, levodopa gel, Duopa, it's effective, but it does require a surgery to get a G-tube placed to have that medication administered in the duodenum or jejunum of the stomach. Phospholevodopa is the Vyalev. That's the newer infusion that I referenced a few moments ago. The Vyalev is a little bit less invasive in that there's no surgery required. So people are really loving that, at least from what I've seen in the clinic, because it's a little cannula that goes under the skin to deliver levodopa. It eliminates the pill burden because it replaces, in many cases, oral therapy. Again, every patient is different, speaking in generalities, but it can be another effective tool in the toolbox to manage symptoms that are bothersome. Now, research, we have to talk about this quickly. I know I talked about earlier, PD generation is a study that the Parkinson's Foundation is running. Again, it's observational, so there's no intervention with that study. If you are interested in clinical trials or other research efforts that involve an actual intervention being administered, whether it be a medication or a surgical intervention, all of those studies will be listed on clinicaltrials.gov. So again, if everybody has a moment to write it down or take a picture of this, it's a fantastic website. It talks in terms of any clinical trial that's being run at multiple centers. So really great information. Further, the helpline again can be so important and helpful in cases of finding research that you might want to participate in that might be right for you. All right. We have reached the end of our talk, and I think I'm okay on time because I want us to be able to go through some questions. But key takeaways for today. Again, Parkinson's can be managed effectively, and there's a lot of treatments out there that can be really efficacious for the management of all the constellation of symptoms that we see, whether it's constipation, a tremor, difficulty walking, falling. We usually have a treatment that we can try. But again, that's with the caveat that everybody's different and people respond to treatments differently, and everybody's case is going to be totally individual to them. Whenever possible, it's great to get a diagnosis as early as possible because this can really help improve the lives of people with PD because they're getting help sooner from a specialized group of people that know this illness and can help tackle it with you along the way. Again, a personalized treatment approach with a comprehensive care team is ideal. So please, I really encourage everybody again, utilize the Parkinson's Foundation for help with finding the right team members if that's something that you're struggling with. The PF is fantastic at not only also helping our people with Parkinson's, but also training clinicians just like me. I was in primary care before I moved to movement disorders in June 2022, and I've remained in neurology, and I continue to do this work with our PD population. And I'm so grateful to that because without the PF, I don't know if that would be possible. So I really encourage everybody to utilize the resources that we were able to briefly highlight today. And I'm happy to answer any questions as they come up. Thank you.
Thanks, Dr. Matulis. Really appreciate you outlining the basics of Parkinson's disease. And there's so much more, again, friends, that we could really dive deeper into. One thing I want to address before I offer you a question, Dr. Matulis. Laura, we have a lot of questions about deep brain stimulation. If you could throw some resources in the chat. We do have a webinar coming up in January specific to deep brain stimulation and advanced therapies. So if that's something that you're more interested in, please tune into those resources resources. We've got blogs, a full web page dedicated to it, a fact sheet about deep brain stimulation. So you can go a little bit deeper of self-study around deep brain stimulation. The first question we received, Dr. Matulis, is from Robin, and they're asking, do patients tend to be more tremor dominant or stiffness dominant? And is that consistent throughout the course of Parkinson's if they're dominant in tremor or stiffness?
That is a great question. And again, I have to say, because I know we've talked about this, but it's so different for everyone in terms of progression. I have seen patients with tremor that do eventually develop stiffness and rigidity, and some people with stiffness and rigidity that never develop a tremor. So it does vary from person to person. What I will say is that tremor predominant Parkinson's disease does tend to progress a little differently than the stiffness and the slowness sector of our people with Parkinson's disease. It's very interesting, and it could be because there's maybe less difficulty walking. You have people that are not as affected with the stiffness and the slowness if they're more tremor predominant, but it definitely varies case to case. I'm not sure I can speak in totality that, this will progress this way and this will progress this way, but generally speaking, there can be those two types. You're totally right, Robin. And on top of that, the tremor predominant does tend to progress maybe a little differently and potentially a little slower because those gait issues are not seen as readily.
It's really fascinating how Parkinson's manifests so differently, depending on the symptoms that you first start with and how it can really progress in the years to come. So I appreciate you acknowledging the unique sort of disposition that Parkinson's offers everyone impacted by it. A question from Jane, and she wants to know if hearing is impacted by Parkinson's disease.
Usually hearing I have not seen to be a consequence of PD, but here's what I'll tell you. And this is my geriatrician brain talking to you right now, Jane. Um, Hearing is hugely important. It's a way we communicate with people. We can't effectively understand and take in what people are saying to us if we can't hear well. Sometimes suspected cognitive issues are not true cognitive issues. They are simply a hearing problem that somebody has. So I say that because as PD progresses, sometimes we expect the cognitive changes. But what I'll say is always plan to get a hearing screening in older age because we might be blaming symptoms on a cognitive process, but it might simply be that a person with Parkinson's maybe can't hear as well just because of normal aging. And it's not a true cognitive problem, it's simply a hearing issue. So I really encourage all my patients, have your regular follow-ups with your primary care doctor, have your regular follow-ups with audiology. Hearing aids are a fantastic way to improve hearing as we get older. And I've seen some patients who have cognitive improvement that because there wasn't any true cognitive issue to begin with, it was simply an issue of hearing. So I love that you brought this up because this is a problem as we age that just needs to be addressed, generally speaking.
I appreciate you acknowledging the hearing of just the natural course of aging as well, and how it could potentially be related to Parkinson's, but to get it checked so we can be sure. Appreciate that, Dr. Matulis. Um, Marcus is asking, what causes a rapid progression of Parkinson's?
That is a fantastic question as well, because I did not go through this. Here's what I want everybody to know. Parkinson's does not progress rapidly. So if you are seeing an acute change in symptoms over, say, 24 hours, a week, a couple of weeks, it's imperative that you get to your movement specialist or neurologist or your primary care doctor to rule out other things that could be going on, because usually it's not the Parkinson's itself that's progressing. There might be a urinary tract infection that's causing the motor symptoms to be worse or the cognitive symptoms to be worse. There could be a pneumonia or a respiratory infection that's viral, that's again causing those PD symptoms to be more predominant than they would normally be. And it's always, I shouldn't say always, but I feel from what I've seen in the clinic, it seems to be a big relief to people to hear, okay, my Parkinson's isn't progressing itself. I should go back to baseline, but I have to address this underlying problem to get back to my baseline. I had a patient come into clinic a week ago and he had a wound on his leg. Parkinson's symptoms were markedly worse, and he and his care partner were very worried that he was having this rapid acute decline that was related simply to the PD. It wasn't. It was the wound on his leg that was causing him to present more prominently. So that's a great question.
Thanks for answering it, Marcus, and for asking it. It's important to hear, what the questions that are arising as we sort of embrace or just starting to learn about Parkinson's disease and its manifestation. So appreciate you outlining that Parkinson's disease is not a rapidly progressive disorder. So we have a couple of questions, Dr. Matulis, around medications and contraindications. I want to invite my colleague Laura, if you could offer the Medications 101 expert briefing that we did, I believe back in September, that can really give high-level overview of I want to say the depth of Parkinson's medications and contraindications to consider. So would you, Dr. Matulis, just talk a little bit about contraindications and Parkinson's medications?
Absolutely. And that's another fantastic question. Everybody's different, but what I'll say is that what people experience can vary. So if somebody has, for example, low blood pressure, that's maybe not even affiliated with the Parkinson's, but maybe a heart condition, we have to be really cautious about increasing levodopa or dopaminergic therapy because those therapies can actually reduce the blood pressure even more. So we have to be careful in that sense. Further, if somebody's experiencing cognitive issues and affiliated hallucinations because of the natural course of Parkinson's, we might have to taper back on some of the levodopa or dopaminergic therapies because those can exacerbate hallucinations, visual illusions, things of that nature. Further, just looking at motor fluctuations. I mean, as we see progression in Parkinson's disease, we might feel inclined to increase the medication, but we also have to look for maybe interactions among other therapies. So I have some people that I want to start an SSRI on for their anxiety or their depression or their apathy, but are they also taking an MAO-B inhibitor that can also increase serotonin on its own and place somebody at risk for serotonin syndrome? So these are just a few examples of what we see when it comes to like taking a moment, thinking about what we're going to be changing in terms of medication management and the things that we want to look for. But this is why we also really appreciate our pharmacists. I want to highlight again the work that they do as a part of our multidisciplinary team. I might have somebody that I'm willing to try a little SSRI with that rasagiline or selegiline for their Parkinson's, but I have the pharmacist calling me saying, I just want to make sure that you're aware of this potential interaction and have you educated your patient. And we love that because it just really fosters that double check that we need. But yes, these are some examples of caution that we express with maybe giving some medications.
That's a great opportunity to engage the expertise of your pharmacist, your local Walgreens, your CVS. They have this in-depth knowledge about medications. And when you go to pick up your medication, whether it be for high blood pressure, diabetes, and Parkinson's, stopping and taking that opportunity when the pharmacist says, do you have any questions? And ask the question. So I really appreciate you offering the opportunity, Dr. Matulis, to empower ourselves as consumers of medication to ask the person who's giving it to us.
Thank you. No, absolutely. Again, these are fantastic questions. I love that everybody brought them to the webinar today. It's amazing.
We are at time, my friends, and I do see that there's a couple of lingering questions in there. I highly, highly encourage you to reach out to our helpline. Before I close this out, Dr. Matulis, are there any final words that you'd like to share with our community?
I just want to thank you all so much again for being here. And as Krista has brought up, please join the other webinars that the PF has coming up. It's fantastic programming. I'm registered for the upcoming supplemental therapies one, so I can learn more about red light therapy in Parkinson's and how we can use that to effectively treat our patients. So I encourage everyone to check it out. And thank you guys so much.
Course. Thank you, Dr. Matulis. And I did see a question about supplements and nutrition and complementary therapies in the Q&A. So I encourage you to find out where you can join us for that webinar next week. So thank you all for joining us today, Dr. Matulis, for your wisdom, your dedication, your devotion to supporting people with Parkinson's. It's felt, and I can really hear it when you bring your heart to your work. So thank you for the work that you do. Another reminder to join us for our annual Care Partner Summit this Saturday, November 8th. This year's theme is Caring with Confidence. Whether you're new to the role of providing support to someone with Parkinson's or have been decades in, I highly encourage you to join us for this conversational format that we'll be having with different care partners with diverse backgrounds and their experience with providing support to someone with Parkinson's. Again, that's this Saturday, November 8th. You can learn more and register at parkinson.org/care summit. And again, if we didn't get to your question or if new ones come up as you digest and integrate the information that Dr. Matulis offered us today, we're here to help you. You can visit our website, parkinson.org, for a wealth of resources on Parkinson's disease, or reach out to our expert team directly. You can call our helpline at 1-800-4PD-INFO. That's 1-800-473-4636. If you don't want to talk and you prefer writing as a form of communication, you can email us at helpline@parkinson.org. All right, my friends, we're ready to support you every step of the way. And through your journey with Parkinson's, may you be well and may you find ease. Until soon.